if you look at the shoulder girdle, we divide shoulder joint into two main parts. The first is anterior shoulder, and then is the posterior part of the shoulder. We scan the patient while the patient is sitting on a stool, and it is appropriate if the radiologist or sonologist or sonographer is standing or is sitting on a revolving stool, which is about 6 to 8 inches higher than the stool of the patient. The stool of the patient is fixed so that we can move around the patient. If you look at the anatomy, we have got anterior shoulder in which we can see the clavicle, and we have the clavicle and acromion, which is the acromioclavicular joint here. This is one important thing which we will be looking in sonography of shoulder joint. Then we have the coracoid process. The coracoid ligament is important here. And then we have the supraspinatus and rotator cuff tendons, like biceps long head is here, and the humeral head, then the shaft and neck of the humerus. This is subscapularis, the broader one. If you look at the posterior aspect, we have got the supraspinatus and infraspinatus with the part of teres minor, which is visible. So we divide shoulder tendons into rotator cuff and non-rotator cuff tendons. Usually on ultrasound, we are looking for rotator cuff, which includes the 5 tendons, which are the supraspinatus, infraspinatus, subscapularis, biceps long head, and teres minor. Ideally, the patient is examined while sitting on a low stool with a rotating backless seat, allowing access to the front side and posterior aspect of the shoulder. So as I mentioned earlier, it is better to stand or sit on a higher stool and move around the patient so we can scan the anterior aspect and posterior part of the shoulder. The examiner is seated adjacent and lateral to the affected shoulder. The arm is placed in a neutral position to begin the examination. This is the neutral position. If patient is sitting on a couch, then obviously we have to stand. We will not have option to sit on a higher stool and move around. So in our setups in developing countries, we usually have a couch on which we are scanning patients for abdomen, gynae, obstetrics, and on same stool, on same couch, we can scan the patient for musculoskeletal ultrasound. Yes, we don't have specific clinical setups to scan only musculoskeletal patients. Otherwise, we could have arranged the stools for them. This is at one of my older clinic in about 2005, where we used to scan the patients for shoulder. This is how the patient will be sitting. We need the shoulders to be exposed. It is obvious that if we have to scan the right shoulder, we will ask the patient to expose the other side, the contralateral side also, so that we can compare if we find any pathology. Especially if there is hypertrophy or atrophy, we can compare the thickness of the tendon on the other side. So although the patient can be examined in a supine position, they must be turned to lie prone in order to examine the posterior components of the rotator cuff. And obviously, a sitting position should be used if possible. We can scan the patient while patient is lying supine on the bed, but it will be difficult to scan whole of the shoulder appropriately. We will not be able to stretch, but if patient is not able to sit, then we will have no choice to let him be lying on the bed supine, and then we can ask him to be prone to see the back of the shoulder. Ultrasound examination of the rotator cuff is best performed with a high resolution, high frequency 7.5 to 12 megahertz linear array transducer, or possibly a curved array of similar frequency where appropriate. So once the transducer has been selected and system setting optimized for musculoskeletal or higher frequency, the rotator cuff is examined in the following order. So the order will be, we have some specific positions which are the positions used internationally. First position is called position number 1. This technique is to see the biceps long head tendon transversely and longitudinally. Neutral supination. The hand you can see is supine. The arm is on the thigh. The hand is on the thigh. The arm is near to the hip, right hip joint here. We try to bring the arm closer to the lateral chest wall, and then this is called position number 1. Then we have the second position, the same, I mean the longitudinal, and then is a transverse. The clip is not working. So first we will put the transducer in this way. Here is the armpit. We will be going about 2 to 3 fingers above the start of the armpit, which is, here we have the acromioclavicular joint, and we are just below the acromioclavicular joint at the line of the armpit, and center of the transducer is at that line. The transducer head is outward. We are scanning transversely, and we will see the long head of the biceps tendon, and then we will move the transducer head upward to have the longitudinal view. Let's see, this is the transverse. We can see from starting from here is the skin, subcutaneous fat. Then we have deltoid muscle. This is the, you can see the the transverse humeral ligament and bicipital groove. In the bicipital groove, we have long head of biceps here. We are getting a cut section, a transverse section. So it will be rounded or a wide in shape. Here you can see, if we give some compression, some pressure by the transducer, we will getting the dipping of the ligament, which is the transverse humeral ligament, which is attached here. But if there is fluid around it, we will see in the part of the pathologies, the lecture which will be dealing with the pathologies of the shoulder joint, we will find that it will be concave shape. The fluid around the biceps will be creating pressure on the transverse humeral ligament, so pushing it outward. So let me repeat it again. This is bicipital groove, long head of biceps, this one, and this white band from here to here. If you look at the finger of this hand, my pointer, this much is the thickness of the transverse humeral ligament. This is deltoid muscle. Then is position number 2. We will ask the patient to move it outward, which is the external rotation. And if there is subluxation, we can diagnose it. Here you can see the biceps long head longitudinally. This is whole of this structure is the deltoid muscle. And once we move it, we will see if there is subluxation of the long head of biceps, it will dip down. I will, once I finish it, I will show you some of the video clips, how they move. So position number 1 and position number 2 was to see the long head of biceps in the bicipital groove, and by real-time movement, we can diagnose if there is any subluxation in the long head of biceps. Position number 3 We will ask the patient to put the arm straight, and that is called neutral position. The arm down on the side, straight, it will be lateral. 7 to 13 megahertz linear transducer is used. We have a acromioclavicular joint here. So you can see the clavicle and acromion. And this one is acromioclavicular joint, this cap. And here, this band, white band, is the acromioclavicular ligament. Then is the subcutaneous fat, and above that will be skin. So by the transducer head is on this side, outer side. We will just move from the armpit, same line, and the center is there. So the center of the transducer is again at the level of the armpit. So this is how we will find it. The acromioclavicular ligament, clavicle, and acromion. So this, once we move it a little bit downward, about 1 centimeter on this side, we can get the subacromiosubdeltoid bursa. So bursa will be below the acromion, this side. We will have another view of it. So this was position number 3 for acromioclavicular joint. Then is position number 4. In position number 4, we ask the patient to put his hand on the back pocket of the same side so that we can have the rotator cuff stretched a bit and we can get the supraspinatus. Here is supraspinatus, and below that will be infraspinatus. This is how we scan. And then we can ask the patient who in position number 4 was on the same side. And in position number 5, the hand is on the opposite side, on the back pocket of the opposite side. In position number 4, it was on the back pocket of the same side. So if it is right hand, we will stretch it in such a way that the hand will be on the right pocket. But in position number 5, we stretch the shoulder more so that if there is any gap between the tendon fibers or there is fluid, it will be visible. Why we put it into 2 positions? Sometimes the patient has got a tear and is unable to stretch up to the position number 5. So for patient comfort, we will not use position number 5. We will scan the patient on position number 4. That's why first we try position number 4 to find any pathology of the rotator cuff, especially supraspinatus and infraspinatus. So we start with the supraspinatus, same transducer, 7 to 14 megahertz is used. So it will look like this. Sometimes we use, in some of the parameters, in some of the guidelines, we use 5A. But in AAIM guidelines, we have 4, position number 4 and 5. We don't have 5A. 5A means while scanning, we will ask the patient to put hand on the opposite pocket, opposite back pocket, and then bring it real time at the back pocket of the same side. So in 5A, we start from the position 5 and bring back to the position number 4. Why we do it? We can have a real-time scanning to see if there is any pathology. I will repeat all the positions again because for shoulder scanning, the positions are very important. For position number 6, we will ask the patient to put the hand on the opposite shoulder, on the tip of the opposite shoulder. So the center of the palm on the tip of the opposite shoulder. So we can scan the back of this shoulder. if we are scanning the right side. So hand at opposite shoulder, again same transducer, we will look for posterior labrum and longitudinal scan, and along with the posterior labrum, we can easily see the teres minor in longitudinal section. The supraspinatus tendon. This is supraspinatus tendon, and this is how we scan. We can put the hand in position number 4 or 5. 4 will be on the same side of pocket, opposite pocket, the back pocket, and position number 5 will be on the opposite side. So the tendon will be hyperaquic as compared to the muscle. This is the bone, periosteum of the head of the humerus. Then the fibular ecotexture, fiber-like structures, convex. The contour is convex. It is of uniform thickness. Then we scan transversely. For supraspinatus infraspinatus junction, we have 2 to 2.5 centimeters posterior to biceps tendon. A slight volume loss, interdigitation of the fibers. So there will be mixing of the two tendons, which will be about 2 to 2.5 centimeters from the center. Slight volume loss is seen. So the thickness will be decreased at the area of junction of both tendons, the junction of supraspinatus and infra. So if there is supraspinatus, we will find the infraspinatus here, and then about 2 centimeters, we will get them having a junction and appearing like one tendon. So that is interdigitation of fibers. Flattening of greater tuberosity when we look at longitudinal section. So this was something about the shoulder techniques. Let me repeat. In technique number 1, we will ask the patient to put his hand on thigh, and it is supinated. There is no gap. There is no gap between the arm and lateral side, so the hand will be like this. Position number 1. And we will put the transducer. This is the armpit, so transducer will be like this. So it will be like this, transversely, and then we rotate it longitudinally, head is upward. While scanning transversely, we will ask the patient to put the hand supinated, and then the transducer head is outward. Then we have our transducer fixed there, and then we ask the patient to move hand laterally outward for position number 2. So position number 2 is to see any subluxation of biceps. Position number 3 is to ask the patient to have hand downward, which is the neutral position, and we put the transducer here to scan the AC joint. Then position number 4 is hand is on the back, same side back pocket, and we look for supraspinatus and infraspinatus. Then position number 5, we ask the patient to stretch it more, and we are scanning the supraspinatus, infraspinatus. Hand is on the back pocket of the opposite side. Then in some of the protocols, like in Australian protocols, they say that we will be needing dynamic examination, for which we will start from 5 and bringing the hand to the position number 4. This is called 5A. For position number 6, we put here. So in all these 6 positions, we will be able to see AC joint, AC ligament, subacromial subdeltoid bursa. We can see deltoid muscle, which will obviously be in our views like here. And then we can see the supraspinatus, infraspinatus, biceps, long head, any flute. So all these structures will be visible. Let's see the normal shoulder sonography. Here it is, shoulder ultrasound. And here are the structures. So on anatomy, you can see the acromioclavicular joint. This is the ligament. Then we have the clavicle here, acromion is here. And here you can see the acromioclavicular, the subacromial subdeltoid bursa. So it is subacromio subdeltoid. It is the largest bursa of the body. And then we have the biceps. Then we have got the supraspinatus and infraspinatus here. If we look at ultrasound, we can find this part as this is the deltoid skin, subcutaneous deltoid muscle. Then we have got the tendon of supraspinatus, and these are the fibers of infraspinatus. So from the center, if we move about 2 to 2.5 centimeters, we will see that fibers are mixing up. This will be moving towards this direction. So this is the junction. Here it is the infraspinatus, then is the supraspinatus, and interdigitation. This is the junction of both at their insertion. The long axis view of supraspinatus, and this is the short axis view. Here a part of long head of biceps transversely visible. This is long head of biceps. This is how we saw that the transducer is placed longitudinally, and we can see the long head of biceps, this one. There will be sheath around it. And if there is fluid, there will be anechoic area, which we will see in the images of pathologies. Here is the deltoid muscle and long head of biceps. This one is the periosteum, the bone, the outer side of the bone. Subscapularis is lying here. So for tendon, we can see it in this position. We can scan for subscapularis in the position number 1 and 2, which is used for biceps. So head of the humerus. And here you can see the subscapularis. We can compare ultrasound with other modalities. Here you can see the supraspinatus and infraspinatus, and here is the junction and acromioclavicular joint. Similarly, here is deltoid. This is deltoid, the supraspinatus tendon, and the greater tuberosity of the humeral head. This is infraspinatus, which is more focused on this view. So biceps, long head, cut section, and we have got the joint. This is the articular surface. We have deltoid, the supraspinatus tendon, and infraspinatus. So sometime interdigitation will make it difficult to differentiate between supra and infraspinatus. But if our scanning area is about 3 centimeters, we will be able to find the difference and even their junction. This is the supraspinatus here and infraspinatus. It is short axis view cut section. Subscapularis and teres minor. We don't get many of the teres minor pathologies. So most of the pathologies are of supraspinatus and infraspinatus or biceps. We rarely find any pathology of subscapularis. While scanning from the back, we can see the posterior labrum, and in the posterior labrum, along with the labrum, this is the labrum, we can find the suprascapular vessels and nerve. This hyperaquic area is the suprascapular nerve, and we have the two vessels on the power Doppler. We cannot differentiate between artery and vein, but here you can see the colors. So notch again and artery. Along with this will be the vein, which we can get it by moving it a little bit. This is labrum, which is very important in cases of accident or fall. We can get tears. So this triangular area is without any line. It is homogeneously hyperaquic. So if we get a black line, it will be a tear. We can easily diagnose. The accuracy of ultrasound to diagnose labral tears is about 86% in literature. So this is how we scan. We can see the back. This is the belly of the deltoid, the supra and infraspinatus from the back. This is the head of the humerus, and the posterior labrum is here, this triangular area. The nerve will be here, and then will be the artery and vein. So we can get that easily. The posture will be either we put it like this, or we put this hand in position number 6, which is putting hand on the opposite shoulder. This is how we scan. And you can see the transverse long head of biceps, the transverse view in this case. Here is the greater tuberosity, the bicipital groove. Here it is, and long head of biceps in the cut section. This is another view in which you can see the supraspinatus, infraspinatus, and long head of biceps. For longitudinal view of the long head of biceps tendon, this is how we put the transducer, head is upward. And this is how we will scan. We will get the longitudinally hyperaquic as compared to the muscle. It is hyperaquic, and there is sheath around it. This is long head of biceps. So for subscapularis, here we can ask the patient to rotate hand laterally, like in position number 2, which I described in techniques, which was position number 2, to rotate it outward. So we can find the muscle is here, and the tendon will be going in this direction. Here is subscapularis. This is the position for subscapularis, and in order to assess the subluxation of the biceps, in which we will find that biceps is coming out of the bicipital groove by moving the arm outward. So once we move it outward, we will see that biceps will slip out, will come out. That is subluxation. This is the subscapularis again. The bicipital groove is here, biceps tendon is lying here. Longitudinal view for subscapularis tendon. Then is supraspinatus. Here you can see for left hand, this is position number 4. We are scanning left shoulder. So the hand is on the opposite pocket of the same side. This is position number 4. We can scan while standing on the back on position number 4. And this is how we will get the supraspinatus longitudinal view. This is supraspinatus again. Another view, transverse section. So patient's hand behind their back, and position number 5 on the opposite side. So we get a better view because it is stretched. So if I am scanning the right shoulder, my right hand has gone on the back pocket of the left side. So it will be more stretched, and we can easily see the texture of tendon. This is magnified view. If patient is feeling pain, we can ask the patient to put the hand this way. This is like position number 5. So this is supraspinatus position 2, which is rotator cuff position number 5. How we differentiate for first and second positions are for biceps and subscapularis. Third position number 3 is for AC joint. And position number 4 and 5, which are for supraspinatus, are also called supraspinatus position 1 and 2. This is how we see the back. We can examine the contralateral side and compare it. Here are the positions for supraspinatus and infraspinatus where we will be finding, and then we are going on this area. But we prefer to scan from the front by stretching it. This is the panoramic view, the infraspinatus, teres minor, and then we have the deltoid. This is another scan of the infraspinatus. For acromioclavicular joint, position number 3 is used, and this is coracoacromial ligament between the acromion and coracoid. For AC joint, we have seen it before. This is where the transducer is placed. Here is the armpit line, and it will be almost center. Here you can see the acromioclavicular ligament, which is this one, this white band, this much. Another acromioclavicular ligament. So assessment of subacromial impingement is important. We can scan the patient's shoulder while putting the transducer here, looking at the acromion and the tendon of the supraspinatus. And we look at it while moving the arm outward. So we will put the transducer here, and we will ask the patient to move hand in this direction. So it will be, while having dynamic examination, we will see any change in the thickness and any pain felt at any posture. This is how we move, and you can see it tipping down while moving. So we need to have acromion and greater tuberosity in view, and we are looking at the movement and width of the tendon of supraspinatus. For posterior glenohumeral ligament and recess, we will see the joint also. This is here, the infraspinatus. This is posterior labrum, the triangular structure, which we discussed before. So we will see if there is any line for indicating tear.